Hello, and welcome to the Parkinson Foundation's Wellness Wednesday. My name is Sarah Maldonado, Community Program Manager for the Parkinson's Foundation in the Southwest Chapter. Today, we are pleased to bring you motor fluctuations and dyskinesia in Parkinson's. Before we begin, we want to welcome those of you who are joining us for the first time and take a moment to share the mission of the Parkinson's Foundation. Every day and in everything we do, we are working to make life better for people with Parkinson's. To achieve our mission, we pursue three goals: improve care for everyone with Parkinson's, advance research towards a cure, and empower and educate our global community. Today's program is a great example of one of the things we are doing to help us meet those goals. PD Health at Home is presented by the Light of Day Foundation, whose generosity has made this programming possible. Thank you, Light of Day Foundation, for your support. We have started a new initiative meant to capture the community's perspective on various topics in Parkinson's disease, like mental health, telehealth, and cannabis. By signing up for this initiative, we will email you up to 4 times a year, requesting that you complete a 10 to 20-minute survey. We will always report findings back to the community and encourage you to visit the link on your screen for more details. I'm now pleased to introduce our speaker, Dr. Neepa Patel. Dr. Patel joins us from Rush University Medical Center, where she is the director for the Movement Disorder Interventional Program in the Department of Neurological Sciences. She is board certified by the American Board of Psychiatry and Neurology and specializes in movement disorders. Her interests include improving the quality and delivery of care for patients receiving deep brain stimulation, and education to improve the utilization of new therapies in movement disorders. Dr. Patel has published several peer-reviewed articles and book chapters related to movement disorders. She believes in providing comprehensive and individualized care to her patients and their families. Thank you for joining us today, Dr. Patel, and I will pass it off to you.
So should I share my screen now?
Yes, that'd be great.
Okay. We are going to do this one. Okay. Everyone see my talk?
Yes, the slides look great.
Okay, perfect. So today I'm going to be talking about motor fluctuations in Parkinson's disease. So I like to start this conversation with just an introduction of Parkinson's disease and its relationship with dopamine. So as you can see here, this is kind of a depiction of how two neurons talk to each other. And the messenger that they use to communicate is neurotransmitters. And dopamine is essentially a neurotransmitter that helps two neurons in your brain communicate with each other to facilitate normal coordinated movements. So the problem in Parkinson's disease, put very simply, is that Parkinson's disease patients start the cells that make dopamine start dying back so that there is less total dopamine to facilitate communication between cells. And it's a very complicated process that we still haven't completely figured out, but in a nutshell, the reduction in total dopamine in the brain leads to many of the motor symptoms that we see and non-motor symptoms that we see associated with Parkinson's. Based on past research, it's up to 80%. By the time patients start experiencing their first symptoms of Parkinson's disease, they are working with 20% of what the rest of us are in terms of total brain concentrations. And more importantly, this translates to about a 60% loss of major dopamine producing cells. Now, this is based off of a very old study, and I suspect that we are better at diagnosing Parkinson's today than we were in the 70s. So it may not be this dramatic of a loss by the time you were first diagnosed with PD, but it is still important in trying to understand how we approach treatment for it. So the next slide, I wanted to kind of talk about the natural history of Parkinson's disease. We very much recognize that the symptoms of Parkinson's disease probably began well before tremor, stiffness, and slowness become a problem and come to the attention of our patients to start seeking medical consultations. But when those initial symptoms are present, many times our patients and families are noticing problems before a doctor can put their finger on exactly what's going on. So in this period, I kind of leave it as they're mild, subtle symptoms, and it may take a little time before a hard diagnosis of Parkinson's is made. And then once we make that diagnosis and there's enough symptoms there to warrant treatment, we start a medication, and more often than not, whatever we start seems to work really well. And we have this almost honeymoon period where your symptoms are dramatically improved, you're doing reasonably well. But as we recognize, this is a short-lived period in the long trajectory of Parkinson's disease. As time marches on, our patients require more medication to achieve the same degree of symptom control. And then something called motor fluctuations or complications develop. And then as time goes on, the medicines don't work as long. You may need to take them more frequently, and dyskinesias may develop. In later stages, and I kind of put an anchor of 7 to 10, but this is on average. So some patients may go 15, 20 years, and some patients may develop some of these complications earlier, like in 3 to 5. But over time, there are going to be other symptoms that are non-responsive to our dopaminergic medications, namely Levodopa, that may become a bigger issue for patients. So we're going to focus on motor complications and the on-off dyskinesias. To talk about this in a different way, and I spend a lot of time with my patients just talking about how to pay attention to your medications. As at a certain point, when you take a medication, it's not going to kick in right away, and it's not going to be a smooth transition. And what some people may notice is that there is some off time, which we describe as low time. Parkinson's symptoms are worse, stiffness is worse, slowness is worse, walking and balance is worse. And then when you take the medication, there's a duration of time. It might be 10, 15, 20 minutes before the medications kick in. Once the medications kick in, a lot of people feel a lot better. And this might be that on time. Now, there are moments where when you feel good and on, you may start experiencing dyskinesias. Alternatively, and this is in majority of the patients, I would say about 60 to 70% of patients will likely develop on dyskinesias at some point in their disease. But there's another phenomenon called the wearing off dyskinesia. And this is when medications are not working at their best, but are not completely gone. And you can have some dyskinesias at this point. Now, the approach to treating off dyskinesias or wearing off dyskinesias as opposed to on dyskinesias are very different. So it is helpful to your doctor if you can help kind of clarify if you are experiencing dyskinesias when they happen in the dose cycle. So I like this figure because it kind of shows the on-off cycling and also represents kind of the progression over time. So as you can see, early into the disease, you can take the medication, it kicks in, and it just lasts the whole time. You take the next dose and it lasts the whole time, and it's a relatively smooth day. But, you know, over the course of years, this window of feeling good shrinks over time. And so our patients will start noticing that wearing off phenomenon, maybe some dyskinesias while they're waiting to kick on, and then peak dose dyskinesias. And this cycling will get worse and worse over time. So a natural conclusion that many of my patients will come to is, you know, Levodopa is bad and it accelerates the progression of Parkinson's. Now, normally, if we were in a live audience, I would survey the audience and ask everyone to raise their hand, but this might be hard in a virtual talk. So I'm just going to put it out there that this is a myth, and truly Levodopa, to our knowledge, is not accelerating Parkinson's disease and is not bad for Parkinson's disease. So I want to take a few minutes to explain why we don't think this is the case. So as you see over here, in a normal healthy person, they're able to regulate and produce dopamine in a normal fashion over time. And there are certain disorders where the production of dopamine is normal, but we still need to supplement with Levodopa or other dopaminergic meds. And we don't see the same phenomenon of developing dyskinesias and this kicking in and wearing off that we do with our Parkinson's patients. And this is a Parkinson's patient as their brain produces less dopamine over time. So we use medication to maintain a comparable level of symptom control or dopamine levels in the brain. And so here at the beginning, you're going to need very little medicine to get back to a normal state. But as time goes on, you're going to need more and then more. And then it's the brain's capacity to manage that levodopa that really influences the development of dyskinesias and a variety of other complications we see. So then I have some patients say, well, if I'm going to need more levodopa over time, why don't I hold off? Why don't I wait until I'm desperate for it because I have disability rather than take it early on in the disease course? Because maybe I'll take less levodopa in 5 years if I don't take any now. So this is, again, another common myth. And my colleagues at University of Cincinnati, I thought, explain this in a really nice chart, which first is this strategy here is if we give levodopa early into this disease course, we can really help influence those minor disabilities that people may feel. You know, it's a little harder to button up buttons. I'm a little slower. I can't keep up. I'm starting to feel limitations from my disease. And if we start treating you then, we can actually keep normal motor functioning for longer. And then, yes, we have to increase levodopa over time, but ultimately you are able to use your body to your best ability. And then I also am a big promoter of exercising to help maintain that muscle strength and muscle memory. And then, yes, you will eventually develop some wearing off and some dyskinesias, but it'll be a lot milder. Your experience with this will be reduced and your cumulative disability will be reduced, as opposed to something like a levodopa delaying strategy where I'm going to wait until I'm really almost falling before I start the medication. Just as an example, where you may start this maybe 3-4 years later than the person I described above, you will have a shorter time with feeling good and having your symptoms less managed. But the development of dyskinesias and that on-off phenomenon will occur at almost the same time period, and it'll be a little bit more aggressive. And this probably has more to do with the changes that happen in the brain related to low dopamine states for 5, 10, 15 years before the onset of motor symptoms. So in general, I think most physicians today want to give you enough medications that you're functioning well and don't have disability, but certainly not so much that we're trying to get you to not experience any symptoms of Parkinson's, because I don't think that's actually an attainable goal. And so a way to kind of summarize this in a simple way is part of the development of motor complications and the loss of that honeymoon period is due to just the progressive reduction of brain dopamine levels over time, because those brain cells are still dying back and our medications are a very sophisticated band-aid. Now, as you start developing these motor complications and dyskinesias, we start talking about alternatives to oral dopaminergic therapies. And so I'm going to spend most of this talk talking about strategies, medication, and otherwise that can help address these motor fluctuations related to more advanced Parkinson's disease. So we have a lot of treatment strategies available for Parkinson's disease. Exercise and rehabilitation are kind of the foundation points of this. And I use it early in disease, I use it in the middle of disease, and I use it at the end of disease. Because as strong as you can be today, the better you are for tomorrow. Then we have medications, and I split them up into dopaminergic therapies and non-dopaminergic therapies. And I'm going to be highlighting primarily the dopaminergic therapies today. And then lastly, we'll talk about some interventional and surgical strategies for the management of symptoms. So a brief overview on how dopamine medications work and the different drug categories. I just want to spend a little bit more time with that 2 neurons talking with the dopamine in the middle, so that you can understand a little bit of why we choose certain medications to treat symptoms, but also why we may say we want more than one medication to treat your symptoms. So as most people in the audience, I suspect, know, levodopa or cinnamate carbidopa levodopa is the most commonly used medication for the treatment of Parkinson's disease, and to this day is still the best medicine to treat Parkinson's disease. So levodopa basically replaces brain dopamine. We're just replenishing the supply and providing it through a pill, which the brain cannot do for itself. So we have to give levodopa because that chemical can pass through the blood-brain barrier. And then it gets taken up into the presynaptic neuron that contains dopamine, that produces dopamine, and then gets converted to dopamine, which is the actual chemical that does the talking between two neurons. And then the brain, the neuron will just release this naturally when needed, and it will signal to the postsynaptic neuron that, hey, start moving. This is, to put it simply, this chemical says, hey, get active, we want to move something. Now, here in the postsynaptic terminal, we have receptors that catch the dopamine and get activated to say, okay, now we need to move. So we have medicines that are called dopamine agonists. These are ropinirole, pramipexole, rotigotine, apomorphine. They don't replace levodopa, but they mimic its actions. We have other medications called MAOB inhibitors, and these actually help maintain more dopamine in this communication zone. So when our neurons release a neurotransmitter, we have to remove it. Otherwise, we'll have kind of an activation that never stops of the next neuron. So we have chemicals that break down the dopamine and help recycle it. So our MAOB inhibitors, which are rastagalene, selegiline, and safinamide, they actually slow down that recycling process so more dopamine hangs out and exerts its effects. And then finally, we have something called COMT inhibitors. This is entacapone and the new opicapone, which help slow down the breakdown of levodopa as it's getting into the brain cell and getting turned into dopamine. So it allows more levodopa to get into the brain and prevents our kind of natural recycling processes. So again, to list this in a different way, we have the MAOB category, the dopamine agonists, the levodopa category, and amantadine. Now, amantadine is a drug that has some positive dopamine effects, though mild, but it also has some non-dopamine effects that are very valuable in Parkinson's. So I am going to talk about this medication. We have a few others that don't work on the dopamine system, but can be valuable in treating Parkinson's. So I've listed them here. So the dopaminergic medications, I apologize, I put this slide twice. The dopamine what I'm focusing today is the non-oral medications. So dopamine agonists, as I mentioned, trick the receptors into believing there is more dopamine than there actually is in the brain. So it can facilitate that communication to help facilitate moving. Now, there are pill versions. Ropinirole is one of them. Pramipexole is another one. And but rotigotine, which is a dopamine agonist, is available as a patch. So there is problems in Parkinson's disease with gut motility. That's why we see a lot of constipation. And so this can actually influence and impact the absorption of medication and may be the reason why we see some on and off delays as disease progresses. So finding alternate methods that avoid the gut system can actually help manage motor fluctuations in Parkinson's disease. So I like the patch because you put it on once a day and it gives you a low kind of coverage of medication all day. And it can often supplement the oral medications such as levodopa so that the cycling impact that you can sometimes experience is a little less intense. Apomorphine, which is currently available as an injectable Apokyn or a sublingual film, Kamobi, are two medications that I like to think of more as rescue. So when you're you take a medication and it does not kick in as expected, you can use this medication to help jumpstart the effects of that while we're waiting for the pill to get absorbed by the gut. Now, these medications, again, bypass the gut system, so may work a little bit faster than our oral medications. The same side effects that we see with most dopamine agonists are still available with the ones that I discussed today. So nausea, lightheadedness, dizziness, can get leg swelling or skin discoloration. And then the two that I really highlight and focus on, because these are important, are narcolepsy-like sleep attacks can occur rarely in less than 10% of patients, as well as impulsive compulsive behaviors, shopping, gambling, hypersexuality. These are new symptoms that is not typical of our patients. So somebody who before having Parkinson's was a gambler is more vulnerable to this, but somebody who was always conservative and never gambled may start developing this problem, mainly due to medications. So it's important to communicate all of these symptoms and anything else that you're experiencing to your doctor, so they may have to adjust your medications to treat those symptoms. Now moving on, we're going to talk about Levodopa. This replenishes your brain dopamine supply. And recently, there was the introduction of Inbrija, which is the inhaled formulation of Levodopa. Now, it's important to recognize that this medication actually has multiple different formulations of it. So another relatively new medication called Rytari is a pill version, but is long acting. So I often use it as well to help with the cycling that comes with more advanced disease. The most common side effect with Levodopa is nausea and vomiting, but it can be associated with lightheadedness, dizziness, sleepiness, dyskinesias, and hallucinations as well. So to go back to our slide, as the disease progresses, what are some approaches to treating the early offs or peak dose dyskinesias? Well, for early off, we sometimes need to increase the dosage of dopaminergic medication. And again, I primarily highlight carbidopa, levodopa, but this could also be your dopamine agonists as well. So you may need to take more medication, and you may need to take it more often. We also often at this time, I talk to my patients about switching to the longer acting forms of the medication so they last a little longer. When the early offs become a little bit more pronounced, we again can also use rescue medications such as the apomorphine, sublingual or injectable, or the Inbrija. And we can also again consider adding more long-acting medications. For peak dose dyskinesias, we have to sometimes reduce the amount that you take per dose, but then give it more often so that you're not getting to such a high peak, you're getting to a lower peak and you're not experiencing as much dyskinesias. And again, there's a lot of value to adding and switching long-acting medications at this point. But as fluctuations develop and progress over time, we need to talk about alternate treatment strategies, many of which are surgical interventions. And we are studying some newer therapies that are only available in research protocols, and I'll touch on that as well. So amantadine is another medication, and as I mentioned, it has some mild dopaminergic effects, but it also has some non-dopaminergic effects, which are very valuable in Parkinson's. And primarily, we use this medication to treat levodopa-induced dyskinesia. So we can actually reduce the impact of dyskinesias by adding this medication on. Now, there are some side effects associated with this. They can cause skin changes, kind of this web-like, reddish, lace-like appearance to your legs called livedo reticularis. They're not harmful or bad, but if it's quite significant, sometimes we need to cut back or stop the medication. It can cause leg swelling, and it can cause skin changes that cause it to break down and develop wounds. So if I start seeing a lot of swelling, I may cut back on this medication preemptively just to avoid some of the later complications. Patients can experience change in vision. I've heard this a lot, but I think in part this might be due to dry eye. Can also have dry mouth, and then it can also cause confusion, changes in memory, and visual hallucinations. So a good dose, a good medication, but there are some side effects that are dose related. So if you experience this at a higher dose, you can still get value from a lower dose. So it's not to say don't take it. It may be worth talking to your doctor about it. So how do we approach treatment? And I touched on that in an earlier slide. I actually recommend using multiple medications in different drug categories to help attack the problem from more than one way. Now, it seems counterintuitive because most of my patients with Parkinson's are relatively healthy before they get Parkinson's. So they were on maybe 1 or 2 medications, if any, before getting the diagnosis. And now I'm telling them they need to take 3 different pills, 4 to 5 times a day. So I spend a lot of time explaining the rationalization behind our polypharmacy. And that's part of the reason I spent some time talking about how the medicine works within the nervous system. So combination of multiple medications at lower doses may avoid side effects than compared to one medication at much higher doses to accomplish the same, to treat the same symptoms. Now we're going to switch gears and talk more about the invasive or surgical intervention, specifically looking at the Duopa pump, the deep brain stimulation, and research protocols. So Duopa is a continuous infusion of carbidopa levodopa for over a 16-hour period. And so as I mentioned, long-acting medications, this is a version of a long-acting levodopa. Probably the biggest challenge that I have in talking to my patients about this is that it does require the placement of a gastric tube. This is essentially a feeding tube, but within that feeding tube, there is a extension cable that takes, that puts the medication right where the levodopa is best absorbed in the gut. So it's a tube within a tube. And this is connected to an external pump that I'm showing here in a pictorial diagram. And the medication looks like this. And patients will receive 30 cartridges and they connect themselves to a cartridge every morning. And then you basically can forget about it until if you're dosed at a high level, you might need 2 cartridges in a day, but otherwise most patients just plug in 1 cartridge, disconnect at the end of the day, go to sleep, and then plug in the next one. This is very effective in reducing off times, and it also reduces on time with troublesome dyskinesia. So patients are getting that better zone of on time without any complications. Now, one other thing that's worth noting is because we're delivering this continuously and it's getting absorbed well, we can actually give less total medication compared to oral pills because we are accepting that we're losing a lot of medication in the gut and in the process of absorption. So I've noticed that some side effects associated with levodopa in higher doses can actually go down. So my patients' blood pressures can stabilize. If they're having mild hallucinations from medications, that can actually improve just by putting them on the Duopa pump. So it is, for patients who have had it, we have young active patients, they're able to swim and do various other things, but it is keeping track of an external pump near your body, but not implanted into your body. Now we're going to talk about deep brain stimulation. And this is a therapy that has now been around for close to 20 years. That was FDA approved, but neurologists and neurosurgeons have been working with this device for close to 30, 35 years. So this is a surgical implantation of a pacemaker-like device into the brain. And that can seem very overwhelming and daunting for my patients. So one of the first conversations I have with my patients is almost all of them say, I really need to be desperate to get this intervention because I don't want surgery. And how I approach talking to my patients about this is that just like I mentioned with the medications, and we want to help you when you're still doing well and starting to experience problems. You are a better surgical candidate at, I'm just making this up, if I was talking about this with a patient at 65 who was maybe needing to take their medications every 3 to 4 hours and starting to notice those dyskinesias and motor fluctuation, this is the time I start introducing the concept so that we get it, we're not impacting their lives too much, and then we're stabilizing their symptoms so that they can continue to live well with their Parkinson's, rather than go through a rapid deterioration, get desperate for the therapy, be at more risk for the surgical complications, And then we're trying to build them back up, and we may not get them back to that same level. So the things to know about it are that there are 3 components that are implanted into the body. So this is all under the skin. We have an electrode, and there's 3 different companies that make this electrode. So I tried to be equally representative to all of them. We have Boston Scientific, we have St. Jude's Abbott, and then we have Medtronic. All 3 companies now today have what we call directional stimulation leads. So that means we can focus the stimulation towards the area that we want to influence and away from areas that we don't want to influence. This allows us to have less side effects, in summary. These electrodes in the brain are connected by an extension wire that usually runs behind the ear, and then is connected to a pacemaker-like device that's usually implanted in the chest, but with rare exceptions, we may implant it somewhere else if this is not a good location for you. Ideal candidates for DBS are patients diagnosed with Parkinson's disease that demonstrate symptoms that are responsive to levodopa. I want to see motor fluctuations associated with levodopa. So if a patient is doing really well on their Parkinson's and they just need to change from 1 tablet to 1.5 tablet of Cinemet 3 times a day, I usually think that's a little too early to take patients to surgery, but it's a good time to start talking about it, because as they need to keep increasing their medication and keep increasing the frequency, we want to get them ready for surgery. It does not help symptoms that do not improve with levodopa. So some of my patients have changes in their speech called dysarthria or hypophonia. If levodopa does not help the symptom, we are unlikely to improve it with surgery. If they have swallowing problems, we're unlikely to improve it. If you have balance issues, balance problems that do not improve with levodopa, or gait changes that do not improve with levodopa, such as freezing of gait, we are unlikely to improve that symptom with DBS. And I put a little asterisk because even if those symptoms are levodopa responsive, say today in the disease, the natural progression of Parkinson's is that postural instability and gait changes will not be as responsive to levodopa. So patients that get DBS and have good response early on may start noticing balance changes over time, because that's the natural progression of Parkinson's. So when it comes to pre-op evaluation, now I'm going to focus more on what we do here at Rush, because every center is a little different. But in general, most of the time we consider how old you are, and age by itself is not a limitation to surgery. More important than that is how healthy you are. If you have multiple medical comorbidities that are uncontrolled, that's going to make you a higher risk candidate. So we may approach that with more caution. I want to always know what symptoms are improving with levodopa. So most centers still like to do a version of a on-off evaluation in the office. That means you come to our office not having taken at least 2 doses of your levodopa, so that we can see you when your Parkinson's is not at its best control. Then we give you medication in the office, usually a little bit more than you usually take, so we can see you at your best performance. And that helps us guide the conversation for expectations. We want to make sure you don't have significant memory problems, because surgery might make that worse if it's already brewing in the background. We want to make sure that you don't have severe anxiety or depression before you go towards surgery, because on the operating room table, you may not be able to cope with that as well. But more importantly, sometimes having surgery can aggravate mood symptoms. And then finally, we want to make sure that you, the patient, and us, the team, are agreed upon what we think can improve and can't improve with surgery. We often, in addition to on-off testing, do neuropsychological evaluations to make sure your thinking, memory, and mood are okay for surgery. And then the team, the interventional team, which comprised of usually more than one neurologist, because there's several that are working together, as well as the neurosurgeon and neuropsychologist, sit down and talk about you. And we make sure that you're a good, safe candidate for surgery. what sometimes happens is we learn that you have some problems that we need to address first before we take you to surgery. After we've addressed all those problems and we think you're a good candidate and you are in agreement that you want to move forward with surgery, we then have you meet our neurosurgeon and then move forward with booking surgery. Finally, for clinical, the last available options to treat motor fluctuations are clinical research trials. And I'm focusing primarily on what we offer here at Rush. So we have some medication or pharmacological research trials, which include a different version of a pump called NeuroDerm. And the pump that we are studying here is actually one that goes through the skin. It's a skin patch pump with small microneedles that deliver levodopa through the skin. So hopefully we can avoid needing to use that gastric tube or the gut tube. We also offer, we're offering a new medication to treat dyskinesias. It has a completely different mechanism of action than amantadine that we're hopeful may provide some relief. And then we have another separate medication in the Tempo 3 trial that is also looking at treating dyskinesias better. Now, we also have some non-pharmacological trials. We have a new ear stim device where you wear a small device on the ear that we believe should help reduce dyskinesias and associated motor fluctuations. And I put focused ultrasound because this is getting a lot of attention and press in our group. We are gearing up, but not ready to accept patients yet for a research study looking at a different target than our tremor patients, which is FDA approved and we're offering as treatment, looking at focused ultrasound to treat PD symptoms. So it'll be a lesion in the basal ganglia system with the hopes of reducing dyskinesias and improving on time. Now, we offer at our center focused ultrasound for medication refractory tremors related to Parkinson's disease. But that's not necessarily an advanced disease state of motor fluctuation. So I didn't spend a lot of time talking about that. If you are interested in participating in research and have a movement disorder specialist outside of our program, you can contact our Rush research team directly and we can screen you and see if you qualify for one of our studies and get you enrolled. Now, we're also more than happy to see you as a new patient if you would prefer that route, but I always make that contact information available to our patients so that you can participate even if you are not a patient of our center. Now, with that, thank you for inviting me to speak, and I'll leave it open for questions.
Great. Thank you, Dr. Patel, for that wonderful presentation. We received some great questions from our audience, so we'll take time to address those now. For those of you who haven't submitted your question, please do so by clicking the Q&A icon on the bottom of your screen. So we'll jump right into some of our questions. Someone in our audience said, I've heard that dyskinesia is primarily caused from the long-term use of levodopa, but not everyone will experience this. Is this true?
So what I would say is if you have Parkinson's disease, which is the degeneration of presynaptic dopaminergic cells, at some point, and it may be 5 years for some, 10 years for others, and 25 years for others, you will likely experience dyskinesias. They may not be severe, they may not be disabling, you may not even be aware that you're having them, but most patients with Parkinson's at some point will get dyskinesias. There's always an exception to the rule, but this is pretty, I think the community kind of believes that this will develop in a Parkinson's patient.
Excellent.
Yeah.
It kind of transitions us into our next questions. Do you have advice for anyone who maybe experienced dyskinesia for the first time? How do you know it is dyskinesia or tremor? And do you have advice for those patients or their caregivers?
Yeah, so first, how to distinguish dyskinesias from tremors. Tremors are kind of a back and forth, really rhythmic type movement. So you can kind of tell by the frequency of it. And for most of my Parkinson's patients, they've lived with it for a long time. So you can kind of know what those resting tremors are or activity dependent tremors are. So it's a very rhythmic movement in a variety of different body parts, but it tends to stay in that body part. A dyskinesia is a irregular, random, twisting, turning, swaying, fidgety type movement. And the best example that I have of a public figure is Michael J. Fox. And he has more advanced disease and has more advanced dyskinesias, but you can see he's swaying, he's rocking. It's not a rhythmic movement. And this can affect any part of the body. So the head, the neck, the face, the hands, the legs, and even the trunk. So for patients who are just starting to experience dyskinesias and they're noticing these new irregular abnormal movements, the first thing I tell everybody is don't panic. This is just a normal, natural problem or symptom associated with Parkinson's. If it's not impairing your ability to, take care of yourself, do what you need to all day, let it be. Well, I'm not going to panic over a abnormal movement but you can eat, drink, dress, and work normally. However, as time progresses, these dyskinesias, albeit minor, may affect balance because your body is swaying or your leg is moving out of your control while you're standing. These are the ones I want to treat because these dyskinesias are impactful or bothersome. So it's always important to bring it up to your neurologist. More often than not, we see it, but we may just make comment of it without bringing it to your attention. So if you're starting to notice it and your neurologist hasn't said anything, it's a good time to bring it up.
Excellent, thank you. So can these motor fluctuations come and go? For example, can it happen one day getting out of bed and then not happen again for a month?
Yes. So again, when they first develop, they're not going to be consistent and regular. And as I'm sure everybody has heard in the audience, no 2 days with Parkinson's disease is ever the same, but no 2 people with Parkinson's is ever the same. So there's a variety of different factors that can influence how well you feel related to your Parkinson's on any given day. And the way I kind of talk to my patients is, one day you might have just gotten a bad night's sleep because you ate something funny and you didn't get a good night's sleep, or you had some worries on your mind. Or the pollen level is at 100% and your allergies are out of control. So whenever you're not feeling at 100% for whatever reason that may be, when you don't have Parkinson's, we kind of just drag a little bit, but we can move on. But when you have Parkinson's disease, your Parkinson's can also appear to be a little bit worse. And the reason for that, to put it really simply, is if you have a gas tank, 80% of your energy on a good day is spent towards compensating for your Parkinson's without even thinking about it. So when you have something else you're dealing with, whether it be stress or, allergies or a minor cold, now you're rerouting that gas tank and you're rerouting half your resources to compensate for this other problem, and your Parkinson's looks worse. Mm-hmm. So that's probably why one day you see dyskinesias and the other you don't.
Excellent, thank you. So we had somebody ask, will dyskinesia move to other parts of the body?
It can. So it can start off in one leg or one arm, and then as time progresses, it may move on to other parts of the body.
Okay. We had another audience member ask, do you know the reasons why some patients with PD might not react well to medications while others do respond well to treatments?
Yeah, so that has to do with each individual person's makeup. Also, just probably not only makeup, but life exposure and life experience. I give the example where I don't take a lot of medicine, and when I decide to take an Advil, I need a nap because it makes me tired. Now, the average person doesn't need to do that. So some people are just more vulnerable than others to medication, and it might also be just the exposure over time.
Great. I know we talked a lot about medications during your presentation, but can you comment on holistic supplements? This person asked about velvet seed powder, and are they a safe alternative?
Sure. So I will start off by saying I am not an expert in alternative homeopathic supplements. So I give kind of a broad brush answer to this, which is apart from a few supplements which we know can interact with our medications or negatively impact Parkinson's disease, for the most part, there's no evidence to say that there is any positive benefit to Parkinson's or related symptoms. But there's also no evidence that says there's any negative impact to Parkinson's and related symptoms. So what I tell most of my patients is, the next big drug is sometimes thought to be helpful, but then we don't do studies for a long time. It's worth talking to your neurologist, making sure there's no major detrimental harm from that. But if you want to take it, I'm not going to stop you. And some neurologists and some specialists have other feelings on it. And the last thing I always tell people is there's a lot of information coming out on just processed foods, processed drugs. And I'm a big believer in try to take everything in its natural form. So my patients will ask me about turmeric pills, and I'll tell them, well, why not eat turmeric, which is a spice and is natural to, rather than taking a processed chemical that extracts some parts of a turmeric. So same idea with all the other supplements.
Absolutely, thank you. So we had somebody ask, do you have any thoughts on phototherapy? So photo helmets and photo pens as a treatment for PD?
I have not heard of that being something that is effective, that's been demonstrated to be effective. And truth be told, it is very new. So I don't know enough about it to speak more to it than that.
Okay, great, thank you. So we had another person ask, how do the medications discussed during the presentation affect or cause low blood pressure?
Absolutely. So I kind of alluded over how dopamine works in the body and made it as simple as, well, if you want to go, dopamine is released and then you go. It's way more complicated than that. So dopamine is throughout the brain and the nervous system, and it has more functions than just movement. It actually helps it's a precursor to another chemical called norepinephrine. So dopamine gets converted into norepinephrine, and norepinephrine actually helps maintain our blood pressure and is released when we need to stand up and move really quickly. So in low dopamine states, to some degree, we're also getting low norepinephrine. Now, other changes that can happen is just our Parkinson's patients' blood vessels don't constrict as quickly and all of that. So as we expose patients to more dopamine, we do recognize that it naturally lowers the blood pressure, but that automatic reflex is also dampened. So it's not an exact, this is the cause, but a lot of different factors go into it.
Okay, great, thank you. Can you maybe review some of the best practices for taking PD medications, specifically Levodopa? Should we avoid taking them close to eating protein, chew tablets for quicker absorption? Any tips you have?
That is a very good question, but one that is loaded. So I'm going to give two caveats. So the first is every individual physician has their opinion, and it's a really good idea for patients to really talk to their physicians about why they feel a certain way about something. And I've worked in my training and just in my career, I've worked with a lot of neurologists, and I've had some that have a hard line that says, absolutely, you need to take it 1 hour before a meal or 2 hours after. It's not 3 hours in total, it's or 2 hours after a meal. Now, when I started talking to a lot of my patients, seeing patients of other doctors as I was building my practice, what I learned is my patients often missed their medication because they got hungry or, life got too busy and they couldn't time their medications and their meals to meet that criteria, and they sacrificed their medication for their meal. And as I've talked to some of my past mentors, one thing is very clear. You, the patient, will know when your meals are starting to affect your medications. And it's hard to plan your meals and your meds if you're taking something every 3 to 4 hours, or some of my patients are taking it every hour and a half. So my general philosophy in all this is take whenever you can, try to keep a distance, but don't sacrifice the medication for food. Take your medicine when you remember it, and I don't care where the food is. What you'll start noticing is, lunchtime, it never works. Now we're going to focus around what you're eating, and maybe we want to move that dose around. And that's a lot easier to work with.
Definitely. Thank you.
Yeah.
So we had somebody ask, they said, I've heard about a pump that does not require surgery. Is that the Duopa pump or something else?
That's the investigational pump. So there's a few different devices out there right now that are called patch pumps. So it's a pump that you connect a patch onto your skin, usually on your abdomen, and then the medication flows through the skin. It's not available for regular prime time, but there are several centers around the country that are offering it.
Excellent, thank you. So at what point is it recommended to look into the Duopa pump? If one is more progressed in PD, could the pump still be beneficial?
Yeah, so one nice part about the Duopa pump is that it's a relatively low risk procedure. So at any stage and phase of Parkinson's disease, we can consider it, as long as our patients are demonstrating levodopa responsiveness and are having trouble achieving that good on time without troublesome dyskinesias. So some of my patients who are struggling with it and are very active might think about it as they're starting to develop those motor fluctuations. And some of my patients will consider it a little bit later as they're struggling. You know, they're taking their medicine every 2 hours, so they're waiting a little bit longer. My philosophy is usually we want to help you stay as good as possible. So we want to think about an interventional therapy, whether that be Duopa or DBS. And for my younger patients with Parkinson's, I encourage them to go towards DBS first because those motor fluctuations will develop again later in the disease course. And we can utilize Duopa then as well. Now, I've had some people do Duopa first and then DBS later. So really is a patient preference, but then also your physician guiding you.
Great, thank you. We do have quite a few questions about DBS. So what factors or conditions rule out DBS? What side effects may result?
Yeah, so probably the biggest factor that would say there's no way we're moving forward with DBS is the presence of significant and severe memory problems. So what we call bordering on dementia or into dementia. Mild, minor cognitive symptoms that are associated with Parkinson's do not preclude you from having surgery. But what I tell people, at least in our program and everywhere that I've worked, we look at you with a very fine-tooth comb. So we're going to tell you, this is going to increase your risk for surgery. This is not an issue. Hey, we found out that you're falling. Why don't we do a round of physical therapy? Let's address that problem before you undergo surgery. So a lot of the complications associated with this, and again, with most surgeons who have experience performing DBS, so we're talking about fellowship trained interventional or functional neurosurgeons. They do this procedure at least 10 to 30 times a year, some more, some a little bit less. And for those surgeons, they know how to approach implanting the device, how to take care of patients in the operating room. That today, this day and age, the complication rates are incredibly low. We have to tell everybody about those risks because it can still happen. So you could have a stroke, a small bleed in the brain is usually the cause of it. You could have an infection related to the brain surgery itself, or the wound breaks open and then you get an infection after the surgery is completed. Rarely, you may get walking or balance problems, but again, these are more often than not short term for the month or two right after surgery, and then most of our patients recover. We do see some rare interactions to having the surgery itself or the device implanted, but that's less than 1% of the population. So I don't spend a lot of time talking about that. And then once the device is in, it's only as effective as how well it's placed. So no matter how hard a team works to get that device in the right place, and I encourage you to talk to your doctors who are involved in DBS to talk about what they do. If it's not in the ideal location, one, it will not provide the benefit that we're hoping to, but two, it might cause some unexpected side effects. And the most common side effects are changes in speech and potentially changes in walking and balance, making somebody's walking and balance worse. Some devices, when we turn on the stimulation, can actually aggravate the dyskinesias before it helps the dyskinesias. So it's sometimes a balancing act, but that's a short-term problem with a long-term positive effect.
So we did have somebody ask, does DBS help with balance issues? I know you mentioned short term, it could get worse, but what about long term?
So in general, I tell my patients, do not expect DBS to help with balance impairment. So if you are someone vulnerable to falling, walking with a walking aid already, it is unlikely to make you not walk with a walking aid. We do not generally expect to worsen your balance from where it is. But I tell people, you know, I undersell and I over deliver. So walking in balance is just so complicated. We can't really say with a lot of assurance that, yep, this is going to get better.
Great. So I think we'll wrap up with this question related to DBS. How quickly is a patient able to resume exercise or rehab services following DBS?
Sure. So every center has a different restriction, but usually it's about 6 weeks after the battery is implanted. And you can do some exercises and rehabilitation before that, but anything that requires heavy lifting or compression of the chest, so push-ups, pull-ups, things like that, we really want to make sure that device has settled in. But I have patients resume, you know, just gait and balance training and some light physical therapy focused on the legs, usually within a week or two after surgery, especially if they need it. Yeah.
Great. Excellent. Well, thank you so much, Dr. Patel. That does conclude our Q&A session. So for those of you with us, we do ask you to stick around for a couple more minutes. We do have a couple more slides to share with you. So again, many thanks to Dr. Patel for joining us. Bye. Thank you. And thank you to all of our attendees on Zoom. We would also like to thank our program sponsor, the Light of Day Foundation, for their support. Today's session has been recorded and will be available for viewing at our Parkinson's Foundation YouTube channel. As our program concludes, a window will open with a link to complete an evaluation of today's program. We appreciate your feedback as we use this to plan future programs. A link will be sent to you via email in the coming days with the recording, the resources we shared, and the evaluation link if you have not completed it already. In addition to our Wellness Wednesday series, we are hosting virtual events each Monday, Wednesday, and Friday of the week. To learn more and register, please visit parkinson.org/pdhealth. To learn more about our virtual programming for PD Health at Home, please visit parkinson.org/pdhealth or call our toll-free helpline at 1-800-4PD-INFO. You can join us next week for our social engagement series, Creative Connections, for a unique and fun experience connecting with others through exploring art. If you had a question today that was not answered, please reach out to us by calling 1-800-4PD or emailing helpline@parkinson.org. You can use that same contact info to order our free resources, educational book series, and our hospital safety kit. Thank you again for joining us today. Stay well and come back soon.